The broadcast is now starting. All attendees are in listen-only mode.
Good evening and welcome to the COVID-19 Updates for Cardiomyopathy Families webinar. Today's webinar is hosted by the Children's Cardiomyopathy Foundation. My name is Cindy Andrake and I am the Manager of Family Support at CCF. We want to extend a warm welcome to everyone on this webinar this evening. But before I introduce you to us presenters, I have a couple of housekeeping items I'd like to review. To provide the highest quality webinar session and to avoid any background noise, all attendees will be in the listen-only mode during the presentation. Your control panel is on the right side of your screen. If at any time you experience technical issues, please type your concerns into the chat window on your control panel and we'll do our best to address any issues you have. If you should have any audio issues or difficulty hearing, you should be able to switch from your computer screen to a call-in phone number to correct the audio. Many of you have already submitted questions. If there are additional questions during the presentation, you can submit them via the question box located on the control panel, and we will address them at the end of the presentation. If the control panel is preventing you from seeing the screen, you can hide it by clicking the small orange arrow at the top left of the control panel. Last, we are recording today's webinar presentation and we'll post it over the next few days on CCF's YouTube channel, which is called CCF Heart Kids. So with that, all of our housekeeping reminders complete, I'm really pleased to introduce you to our speakers this evening, Dr. Daphne Hsu and Dr. Neha Bansal. Dr. Hsu is a professor of pediatrics at Albert Einstein College of Medicine and the chief of pediatric cardiology and co-director of the Pediatric Heart Center Children's Hospital of Montefiore in New York City. She is one of the nation's leading experts in children's heart failure and heart transplant. Dr. Hsu has treated more than 600 children with heart failure and more than 250 children undergoing heart transplant. She is the past president and board member of the Pediatric Heart Transplant Study Group. She also sits on the boards of the Pediatric Cardiomyopathy Registry and the Adult Congenital Heart Disease Committee for the American Heart Association. In addition to authoring dozens of peer-reviewed cardiology studies, Dr. Hsu reviews pediatric cardiology-related grants for the Food and Drug Administration and the National Institutes of Health. She is a member of the Pediatric Cardiology Subboard of the American Board of Pediatrics. Dr. Bansal is an attending physician in the Department of Pediatrics at the Children's Hospital at Montefiore and an assistant professor of pediatrics at the Albert Einstein College of Medicine. Her clinical focus is pediatric patients who have heart failure due to cardiomyopathy or congenital heart disease, as well as pediatric transplant patients. She is also interested in echocardiography in the setting of heart failure, as well as cardiac care of survivors of childhood cancer. In 2017, Dr. Bansal received the Children's Cardiomyopathy Foundation and the Kyle John Rzuski Foundation Research Scholar Award. She is board certified by the American Board of Pediatrics and a member of numerous professional societies. I want to thank you both for being with us this evening. On behalf of the CCF committee, I really want to extend my sincere gratitude for sharing your expertise on this pandemic and for giving your time to us this evening to answer our concerns. So at this point, I am going to turn the presentation over to Dr. Bansal, and she is going to take the rest of the presentation.
Thank you so much for that introduction, and I thank the CCF as well as Daphne for giving me this opportunity of presenting today the concerns of COVID-19, especially in our CCF family. So we're going to be discussing the latest report on COVID-19. We're going to be talking about the risk of COVID in patients with pediatric cardiomyopathies. We're going to be talking about the MIS-C or the PMIS syndrome. We're going to be discussing the findings of the CCF survey that has been rotating for the past few weeks. And we're going to be talking about some reopening strategies. So talking about the latest report on COVID-19. So overall, worldwide, as we know, there are more than 6 million cases. There have been about 383,000 deaths. In US, we have about 1.8 million cases. And now we have crossed 100,000 deaths in the United States. Looking at the US map, over here you can see the dark blue are the states where the caseload is more than 40,000 patients. and the white are less than 1,000 patients. So as you can start to see, that reopening strategies become challenging, where the disease is variable. Disease prevalence is variable. Looking at the total number of cases, the states that are worst hit are New York, New Jersey, and Massachusetts, with the maximum number of deaths. Now, looking at the pediatric studies, this is a dashboard that is maintained by 184 pediatric ICUs across North America and Canada. And as you can see, that this is last updated as of yesterday. In the pediatric ICUs, they have had about 565 COVID positive patients, pediatric patients, and 31 confirmed deaths due to COVID-19. So as you can see, small numbers from 184 centers. Looking at their daily census, the gray line represents the total number of positive daily cases, and the blue line represents a rolling 5-day average daily census. So you can start to see that in early April, we started to see a rise in the number of cases. The case high continued throughout April and May, and now in early June, we're starting to see the number of cases come down. Looking at the age distribution of these cases, these are, again, pediatric patients with COVID-19 admitted to the ICU, so requiring a pediatric intensive care setting. We can see that majority of the patients are teenagers from 12 to 18 years, and then the rest of the pie is made up by other patients, some of them also more than 30 years, as we had opened our ICUs to help our adult colleagues for a period of time. Looking at the organ systems that are involved by COVID-19 in pediatric patients, the top three are the respiratory system, circulatory system, and the digestive system. As we also saw some patients present with GI symptoms of diarrhea, abdominal pain. This was pretty prominent in the pediatric population. Looking at patients with history of comorbidity who required an ICU level care, you can see an overwhelming majority of them had no history of comorbidity and were previously normal, healthy kids, some of them with mild comorbidity, and few of them with moderate to severe. So about a quarter, a little more than a quarter, but a majority, close to 50%, were normal kids. Looking at these patients, if they had history of immunodeficiency, any sort of immunodeficiency, you can see 91% of these patients did not have any history of immunodeficiency in the past. Talking about risk of COVID in patients with pediatric cardiomyopathies. So unfortunately, there is no published study exploring the prevalence or incidence of COVID-19 in pediatric patients who have pre-existing cardiomyopathies. Anecdotally, since in New York City, we have had the experience of taking care of a lot of these patients, we do not think that it is any different from normal pediatric patients who do not have history of cardiomyopathy. We also have the PHTS dashboard, which is going to tell us patients who got transplanted, have a history of transplant, and how many of them were COVID, the prevalence of infection in that population. And then we have the CCF survey, and that was the purpose of our survey, to explore what is the risk in our pediatric cardiomyopathy patients. So looking at the Pediatric Heart Transplant Society, which is the PHTS COVID-19 dashboard, this was updated as of May 26th. There were a total of 6 cases. 4 of them were swab positive. 2 of them were presumed COVID-19 positive. The median age of these patients was about 10 years, and 2 of them were male, 4 of them were female. 3 of them required hospitalization, but all 6 of them have complete resolution at 30 days from the infection. talking a little bit about the MIS-C syndrome. So in April end, about 26 April, that was 1 month after the COVID-19 peak, there was a UK alert for the disease, which was overlapping with Kawasaki disease and toxic shock syndrome. This came from the UK. Around May 4 to 6, we started to see in New York City an alert because we saw about 64 cases in children, and there was a request to report such cases to the New York City Department of Health. There was a case definition by New York Department of Health that was published on May 13th, and CDC case definition came out on May 14th. And May 15th, there was recognition by the WHO about the guidelines and the alert about this, the PMIS or the MIS-C definition. So you can see the very quick timeline. So what is PMIS, or MIS-C? So it is multi-system inflammatory syndrome in children. So there are 3 aspects of this that are required. The first being a current or past SARS-CoV-2 infection or exposure, and inflammation of equal to or more than 2 systems. Now this includes systems like the heart, the lungs, the kidneys, GI system, the eyes, so multiple organ systems that get involved, and a history of fever. So this is what comprises the case definition of MIS-C. In New York City, almost all children fit this criteria as they are exposed to SARS-CoV due to the high prevalence of the infection. So multi-system inflammatory syndrome in children, or MIS-C, it is a condition where different body parts can become inflamed. The cause, unfortunately, of this syndrome is unknown at this point in time. Many of these children with MIS-C had the virus that causes the COVID-19 or have been exposed to this virus. And MIS-C has been shown to be serious, but most children who get diagnosed with this inflammatory condition have gotten better with medical care, and this is as per the CDC website. Now, going back to our ICU care, ICU patients from the website, looking at all the patients who were admitted, we saw about a 50-50 distribution in patients who were admitted to ICU who had MIS-C and 50% who did not. At Montefiore Health System, Children's Hospital in Montefiore, we saw about a month after, as you can see over here, the peak was somewhere in mid-April, and then about a month later, we started to see the rise in MIS-C patients. However, these are our patients at Children's Hospital at Montefiore, and as you can see that even though a lot of them had myocarditis or depressed function initially when they presented, they very quickly recovered, some recovering just 2 days after their presentation, and some recovering about 10 to 14 days after their presentation. But by day 18 to 20, all of them had recovered their cardiac function, and a lot of them were discharged very soon after presentation. So as I said, all children who were diagnosed have gotten better. Talking a little bit about the findings of the CCF survey. So the CCF survey is an online anonymous survey that was published on the CCF website. I encourage you or the families that you know who have children with cardiomyopathy to go ahead and take part in the survey, because it really helps us, it helps our families understand this disease and the prevalence of this disease in our patient population. So this is the website. We had about 65 responses till date for the survey. So just to show that majority of the families that responded to the survey belongs to the US, about 88%, but we had about 10% responses from Europe. 72% of these families had patients with primary cardiomyopathy who had not received a heart transplant, and about 23% of them had received a heart transplant. Looking at the makeup of cardiomyopathies, 41% of the patients have dilated cardiomyopathy, and about 35% of the patients had hypertrophic cardiomyopathy, with small parts of the pies being made up by other forms of cardiomyopathy like non-compaction, arrhythmogenic right ventricle, and restrictive cardiomyopathies. Looking at the age makeup of our families, as you can see here, it is almost equally distributed from 1 to 3 years, majority being formed by 14 to 18 years of age, 23%, 20% of them being 4 to 7 years. So across almost all age groups. And looking at the gender makeup, 54% of our patients are male and the rest are female. So just looking at how many of the families, how many of the patients were previously on ACE inhibitors and ARBs. So as we can see that 61% of the patients were not on ACE inhibitors and 92% patients were not on ARBs. There was a statement by the ACC and AHA that recommended to not stop the pre-existing medications that Dr. Hsu mentioned in her previous webinar. But this is just how our population is. So now coming to the COVID-19 related questions. In the last 3 months, how many of the patients experienced symptoms of COVID-19? Symptoms including fever, cough, shortness of breath. So as you can see here, overwhelming 57% of the patients experienced no symptoms, though there was 43% of the patients who experienced some symptoms. And so if you had symptoms, any of these above symptoms of fever, cough, and shortness of breath, about 55% of these patients did seek medical attention about their symptoms. Just going back further in the past 12 months, we wanted to know how many of these patients had any pre-existing conditions that could predispose them to COVID-19 respiratory illness, ARDS. And as you can see here, about 57% of them had no pre-existing lung infection or lung pathology that was treated. So of the patients who did seek medical attention, 89% of the patients did not get tested for COVID-19. Only about 11% of the patients were tested. And I think this is the most important pie chart over here, that of all the patients that were tested, so 7 patients who were tested, they were all 100% negative for COVID-19. So just to show that they're not at a heightened risk of getting COVID-19. All of them tested negative. So there were multiple reasons for not getting tested. For example, the testing was not freely available. 37% of the doctors did not recommend, did not advise testing at the time. And of course, this is hard to decipher because testing across different states the availability of testing has been variable across different states and as well as nations. So just talking briefly about some possible reopening strategies. So we need to first address what we don't know yet. We are still learning about MIS-C and how it affects children. We do not have a complete grasp on what are some of the long-term effects of this syndrome. However, our over the last few weeks, having had actively taken care of these patients, we know, especially at Children's Hospital in Montefiore, all our patients have recovered completely. We also don't know why some children have gotten sick and others have not. As you can see from our survey, as well as the patients who require ICU care, there were 50% of them who had no pre-existing comorbidities. So it is unclear as to why some children get sick and others do not. Are children with certain health conditions more susceptible? So especially talking about pediatric cardiomyopathies, as you can see from the survey, the overwhelming response is that probably not. They are probably at equal risk as any other pediatric patient. As I said before, the long-term effects of both COVID-19 and MISC is yet to be determined. And then talking about a vaccine, given the unknown pathophysiology of MISC, we think that whenever a vaccine does become available, safety will need to be assessed, especially in children, prior to it being administered. And we will, of course, have the WHO and CDC guiding us through these processes. So as we start to slowly reopen, certain points that we think that should be considered, that stay at home to slow the spread, especially any unintentional travel, like travel that is not important, and especially if you're sick, you should stay at home. Using hand sanitizers frequently and washing your hands, frequent hand washing, hand hygiene is extremely important. The Action Network and the PHTS have taken out these flyers where they say to try to sing happy birthday twice slowly. That tells you it's about 20 seconds. Keeping your hands from touching your face or constantly touching your face, it is very tough. And this is where the CDC recommendations of masks may not be the best in kids less than 2 years of age, just because toddlers, especially because they constantly keep touching their face when they have their masks on, might be counterintuitive in the masks, how they help. Remember to take all your normal medications. There are no guidelines to stop ACE inhibitors or ARBs, and they have not been shown to have detrimental effects with COVID-19, both in adult and pediatric population. So we should just remember to take all our medications. And then social distancing, even though the country is reopening, remembering to stay at least 6 feet apart from other people, which is equal to the distance of a width of a couch, of a normal couch, is important. So these are some of the guidelines from the WHO and the CDC. So is wearing rubber gloves while out in public effective in preventing the infection? And they say no, regularly washing your hands offers more protection against the COVID-19 than wearing the gloves, because if you're wearing the gloves and you touch something that is contaminated with the virus and then touch your face, the contamination is transmitted via the glove from the location of the contamination to your face. So it's not really protective. Instead, frequent hand washing has been shown to be extremely effective in preventing the spread of the virus. The washing your clothes and linen, especially if you have nobody in the household suspected with COVID-19, you should just wash and dry your clothes as regular. There's no special precautions that need to be taken. How do I wash my fruits and vegetables? The same way as you would before. However, it would be great if before you wash your vegetables, you wash your hands, so that if by chance you have any COVID-19 contamination on your hands from the packaging or from the grocery store, that you wash them prior to handling your food. And practice hand hygiene, especially for people who are taking public transport. After you leave the transit station, as well as when you arrive at your destination, so that you avoid contamination. And wearing masks. The CDC allows for any cloth protection in areas where you cannot maintain social distancing. So, so following CDC recommendations, WHO recommendations, as well as following local DOH recommendations for your locations. As you saw in the map that I showed you earlier, the prevalence of infection across the states is very different. So what may be recommended in New York City may be very different from what is recommended in, say, Montana. Practicing strict hand hygiene, that has been proven to be the most effective method of preventing the spread. Continue to social distance, maintaining a 6-foot distance from other people. Washing your hands with soap and water for 20 seconds. Avoid going to crowded places unless if it's necessary. And then CDC recommends wearing cloth face coverings in public settings where social distancing measures are difficult to maintain, especially in areas of significant community-based transmission. So like I said, again, these recommendations may be variable for places where the infection prevalence may be different. Do not stop your prescribed medications. We also feel that it is important to follow up with your doctor for an appointment. The telehealth visit versus in-person visit will be dependent on your physician. If you are overdue for an EKG or an echocardiogram, it may be imperative to see your doctor in clinic. However, if you're stable and you recently had a follow-up visit right before the pandemic started, your physician may feel that it may be safe for you to have a telehealth visit. However, you should touch base with your physician, the doctor of your child, to determine what would be the ideal way to follow up. Just addressing the anxiety of people to go into clinic settings. This is something that was made by the ACTION community as well as the PHTS community. So how will the hospital try to keep you safe? So everyone who enters the hospital will be screened for illness. At Montefiore Hospital, we are doing pre-screening for all the patients who are coming to our clinic via telephone to inquire whether anyone has symptoms. We are, and as at the time of entering the hospital, we have all the members of the staff as well as all visitors who are screened, who have a temperature check, and they're screened for any illnesses. There may be you may be examined by only one provider instead of multiple providers. Your care team may be talking to you via telephone or video conference line. This is sometimes possible, like I said, in telehealth visits if the physician feels that it may be safe for you to have one. The healthcare providers may be wearing masks and gowns sometimes, face shields, just to prevent transmission to your family. As well as to protect themselves from the transmission. These policies obviously will change depending on how many in your area have the virus. And visitor policy, so at Montefiore Hospital, we allow one parent per patient to come into the clinic visit, and those policies may change, especially for inpatients as well as outpatient, to decrease exposure to not just the patients, also the healthcare providers to COVID-19. And of course, if you're admitted to the hospital, food offerings may be limited at some of the cafeterias, may be closed. Just something to keep in mind if you have a long clinic visit planned. Oops, sorry. So in summary, we know that the COVID-19 total numbers, there is reducing number of cases in total. The multi-system inflammatory syndrome in children, or MIS-C, is a developing disease. We're slowly learning. However, all the children who were admitted to our hospital with MIS-C have recovered completely. There is no data to identify that the pediatric cardiomyopathy kids are at higher risk of getting infected with COVID-19, or when infected, there is no indication that they get severely sick from the virus. The CCF survey is very reassuring that all the 7 patients who were tested negative. As the country reopens, we should all continue to take precautions. It's very important to teach your child strict hand hygiene, frequent hand washing, using the hand sanitizers, maintaining social distancing wherever it's feasible. And we recommend that you follow your local Department of Health recommendations, as well as follow the CDC and the WHO for their recommendations. We advise that you keep taking the medications that you're prescribed and follow up with your cardiologist. Touch base with them to determine whether you need a telehealth visit or an in-person visit. And last but not least, we really encourage everyone who has not yet participated in the CCF survey to go to the website today and participate. The more responses we get, the more information we get, the more we can address the situation. I thank you very much for listening to me. I thank the CCF for giving me this opportunity, and Dr. Daphne Hsu for giving me this opportunity to present our data. Thank you so much.
Thank you so much. That was excellent. We do have some questions that people have submitted, and I'm just going to read them out, and you can just jump in and answer, either one of you. So the first question is, do you recommend a child with cardiomyopathy continue virtual learning in the fall?
So that is that's the big question in everybody's mind, is what should happen as schools open. I think that the local recommendations for the schools and the local ways the schools are addressing what they're going to do about social distancing as schools open are going to be very important for parents to consider as they think about going back to school. There are many benefits to going back to school for children. We know that children need to develop by forming social bonds, by being able to function within a school environment, and it's just as important for the cardiomyopathy kids as the non-cardiomyopathy kids. What we're seeing is that the cardiomyopathy children who are well and not in heart failure are doing well, and I expect that they're going to do as well as any other child with COVID. And children with COVID do extremely well. So it's important to keep that in mind and not make decisions based on the worst case all the time in order to try to protect your child, because they can't live in a bubble the rest of their lives. So the question is to the schools, what are you doing to social distance? What are you doing to ensure that children are doing everything they can to keep themselves in a situation where they're not going to transmit the disease? That doesn't mean that they will never transmit disease. Of course, children will be children and get close to each other, but I do think that the schools are going to be able to make accommodations so that children will be learning farther apart. And in that case, you might very well want to say, my child should go back to school. It also might depend on the age of the child. The smaller children, it's more difficult to keep them isolated, more difficult for them to understand what it's like to keep themselves a little bit more distant, so that as you get into the age range of 10 to 12, children can start to understand that. And the smaller children, it might not be possible. And daycare, it might not be possible. So you have to start to consider whether or not you can assure yourself that your child will be able to be taken well care of and social distance and wash their hands in certain settings. Are there enough adults available to supervise them?
Okay, great, thank you. Next question is, when vaccines become available, how safe is it for cardiomyopathy kids?
I think I briefly addressed that in the webinar, where once the vaccines do become available, we will need to assess the safety in all pediatric patients, not just pediatric cardiomyopathy patients. And I feel like once the safety is assessed, we would have the answers, because the pathophysiology of MIS is still a developing disease. We don't know whether it's antibody mediated. We don't know how it works. And so I think that's still a question that is unknown.
Okay.
I do think that if it's determined to be safe for children, it will be safe for children with cardiomyopathy.
Okay.
The big question in people's minds is, will it be safe for children who have heart transplants and who are immunosuppressed? In the same way that we address it with any of the live vaccines. So at the time of vaccines available, if it's determined to be safe for children, I would encourage all children, including children with cardiomyopathy, to get the vaccine. It may not be available for children who are immunosuppressed because they might not have enough information to say it's safe. And in that case, your child couldn't have it. But if you can have it, they feel it's safe, you should get it, because certainly the vaccine and giving you protection is going to be better than getting the disease.
Okay, Great, thank you. So are the risks for COVID-19 any different than any other virus for kids that are waiting for transplant?
So just practicing hand hygiene, practicing social distancing, I feel like has been successful for us personally at Children's Hospital at Montefiore. We had a patient who we transplanted a few weeks ago who was in the hospital, and just by practicing adequate hand washing and social distancing, limiting the number of people who that patient needed to see, only the care team, limiting the number of visitors, we were able to get that patient successfully to transplant and now home without the patient ever catching COVID-19.
And I think every hospital that's doing transplants is being extremely careful with their patients before. So you'll see if you're in the hospital and you're waiting for a transplant, that people will be wearing full PPE when they come to see the patients. The families are being asked to limit the number of visitors. And that's actually been extremely effective. If you look at the number of healthcare workers who've been infected in New York City with COVID-19, it is lower than the general population. I think that is because people in the hospital are aware of the proper ways to do social distancing and wear their personal protective equipment. So if your child needs a transplant, they need a transplant. The center will do everything they can, and it's shown to be very effective across the country to do the practicing. All the isolation procedures are very effective, so that you should go for the transplant and not be concerned. Our concern is that people will not want to proceed with transplants and then will become sick from their original disease, which is a pretty serious complication.
Okay, thank you. So some of these questions probably were addressed during your presentation, but they were submitted anyway, so I'll read them. What are reasonable and necessary precautions other than quarantine and minimizing contact with others to prevent COVID-19?
Yeah, so I think hand hygiene is definitely something that we should teach all our kids, because hand washing, using a hand sanitizer frequently, and then of course social distancing where necessary, where we can, and where we cannot, wearing masks, just to prevent the transmission of the virus. I think those are important factors to consider.
Should kids with cardiomyopathy continue to quarantine as the country begins to open up?
It's the same answer as school.
Mm-hmm.
You have to understand what's going on in your local community. And I think that people will need to get out, and children will need to get out. They'll need to see their friends. So we try to do it in a way that's recommended for what's happening in your community. Some communities have very low incidence of COVID-19, and you can be much more sort of relaxed about it. And the ones that have a higher incidence or a rising incidence of COVID-19, you have to think more carefully about how to open up.
Okay. So are children with cardiomyopathy more at risk to develop the Kawasaki-like disease or the MIS-C disease?
I think just looking back at our personal data, anecdotally, we did not have any kids who had prior cardiomyopathy present with MIS-C. So I don't think that we have any data to show that they are at higher risk. I think we just have to assume that they are at the same risk as other patients.
Okay. Are children with asymptomatic cardiomyopathy at higher risk to develop complications if they contract COVID-19?
No, actually, we have not seen that. Like you saw in the data that I presented from the ICUs across the country, a lot of the patients had no previous comorbidities. They were normal, they were healthy kids, and so we did not see that at our center.
Okay.
I think that's the point. The asymptomatic child with cardiomyopathy without heart failure is probably not at increased risk for complications for COVID. Now, all children are at risk for complications of COVID, so they're not protected, but they're not at increased risk. There are children who have active heart failure, who are having trouble with fluid in their lungs, who are on the road to thinking about a transplant. Those patients we don't know for sure, but I think would become more ill if they had COVID, because they are more like the adult patients who know with heart disease, with heart failure, do have a predisposition to have more complications. But those are truly patients who have symptoms. And luckily, most of the cardiomyopathy patients we see in the office don't have symptoms. They're well controlled on their medications.
Mhm.
I think those children are going to do quite well, even if they get COVID.
Okay, well, this last question was, in light of all the Kawasaki-like disease associated with COVID-19 in children, would a child with cardiomyopathy who has normal cardiac function be at a greater risk for a decline in their heart function if they contract the virus?
So some of the patients who presented to our hospital did have a transient decline in their heart function. However, like I said, a lot of them, all of them recovered their heart function. It is unclear if patients with cardiomyopathy would recover the same way as fast or as quickly as the other patients, but there's no data to indicate that that they would be at a higher risk of having heart failure from the COVID-19 virus.
It looks like this MIS-C syndrome is an inflammatory syndrome. It looks like COVID is somehow stimulating the body to have a super inflammatory response. That's really not something that children with cardiomyopathy have. So there are two separate problems. And so that we don't think that one predisposes you to the other, and we don't think that one will make the other one worse. But if you did add on MIS-C to a child with poor function, it could make them certainly sicker.
Okay.
It's a very rare disease, the MIS-C. If you saw in New York City, they were reporting 60 patients out of the, I think in New York there were about 150,000 patients with COVID at the time. So the incidence is extremely rare, even amongst the children who are infected with COVID.
Okay, thank you. And this last question that just came on is, it's more of a statement or a comment. The writer said, it's interesting that GI symptoms were not listed as COVID symptoms on the survey, but that it's a common pediatric symptom. Any comment or?
I think I did not present all the aspects. I think when we first made the survey, a lot of the patients were coming in with just the respiratory symptoms, but I think in the list of all the symptoms, there is GI symptoms as well that we inquire about.
Okay.
And we certainly have an other. So if you have a child that had active GI symptoms with COVID, we'd love to hear about that, because it's true that the late presentation of COVID does seem to be children presenting with abdominal pain and diarrhea. We didn't really go over the symptoms of MIS-C, but we do talk about kids with fever, and two of the symptoms, such as abdominal symptoms, respiratory symptoms, trouble becoming dehydrated. There are sort of criteria that you say if you have a fever plus these two things, you have to think about in the time of COVID that it might be a COVID-related illness.
Okay. So somebody just said, we have another question. I have been so fearful of letting my boys with HCM out of the house or out of the door. Kids need to be kids. So thank you for this information. So I think we've gotten to everything that we wanted to cover. We've gone through all the questions. I really appreciate your time. It's been a long day for the two of you, and I appreciate that you gave us your expertise this evening. I want to remind everybody that if they do want to complete the survey, they can go to the Children's Cardiomyopathy Foundation at www.childrenscardiomyopathy.org. And there is a button for COVID resources, and they can log on there and they can take the survey. We were asking that people complete the survey if they've had symptoms of COVID, if their child had symptoms of COVID. Just also want to remind everybody that this webinar will be available on our CCF YouTube channel. It probably won't get up there till tomorrow. The YouTube channel is called CCF Heart Kids. It's all one word. And with that, I just want to thank you both for giving us a wonderful presentation this evening. I know that you answered a lot of our questions. And we do have a last minute question here. Can I ask you this one?
Yeah, sure.
Okay. What about someone with severe DCM, EF of 25%?
Again, I think that what you have to think about is, number one, does that child have symptoms? There are certainly kids who have an ejection fraction of 25% who have trouble breathing and can't exercise and can't do what they need to do to have a normal life. And I think we are more concerned about those children who have active clinical heart failure. But there are also patients with DCM who are running around and acting like normal kids. And in those patients, it's a little less concerning to think about COVID affecting them, because I think that the effect of COVID on the body is mostly in patients who have lung disease, that strong correlation with any kind of lung disease and bad outcomes in eating and having patients who don't do well is very, very obvious in the adult and the pediatric population. So it's not the number of EF, it's really sort of it's really more how your child is. And of course, the best thing to do is to talk to your doctor. They know what's going on in your community, they know what the issues are, they know how the prevalence of the disease is changing, and they're going to be the best ones to say, your child right now should stay at home, or your child can go to school now. We know what's going on at school in our state, in our region, in our city.
Okay. Great. Thank you both. We've gone through all the questions. And again, I want to send my heartfelt thanks for you to give this presentation tonight and for being with us. Thank you both.
Thank you. Thank you so much.
Thank you. And
So
everyone,
if there's anything we can do, if you have any questions, please feel free to get in touch anytime.
great. Thank you all. Have a great evening.
Thank you.
Bye.
Bye.